This topic on constipation is a little artificial. What I want to do is touch on 4 diseases that are going to be really high yield for your testing, and then glance over some of the things that might actually cause a kid or an infant to have decreased bowel movements. The very first thing I want you to do when you begin talking about slow colon is to divide it up into age. When does it happen? That is it a failure to pass meconium, or is it constipation in general? There's lots of ways to define these things. For example, constipation really is any decrease in frequency or increase in difficulty or hardness of stool. Very vague. But basically, it's a change that goes from I can poop to I'm having trouble pooping. Failure to pass meconium means nothing comes out the bottom end in 48 hours. Most kids will pass meconium by 24 hours. If it's been 48, it is absolutely abnormal. And now we talk about diseases that could present as failure to pass meconium because if you have an obstruction anywhere from your esophagus to your anus, whatever you put in your mouth can't make it to the other side. So we talk about some of the diseases that might present with a failure to pass meconium in a bilious emesis lecture. So I don't want you to think that these are the only diseases you have to know. It's just the only ones that are super high yield for the test. The 3 I want you to know about are imperforate anus, Meconium ileus, and Hirschsprung's. And I've put Hirschsprung's here because it is possible that Hirschsprung's presents not in failure to pass meconium, which occurs in the first day of life, of course, 24 to 48 hours, but basically the disease will be present at birth. Hirschsprung's disease may also present as constipation, which is generally going to happen in year 2. That is definitively not present at birth. The other disease I want you to know about, other than Hirschsprung's for constipation, is voluntary holding. And of course, when you're considering a kid with constipation, it's more likely going to be something else not nameable. Things like problems with medication, diet, anatomy, or rare, some neurologic problem. So again, I don't want you to think that these are the only diseases to consider, but for the test, these are the ones you should learn. Let's start off with the one that's the most obvious, and that's imperforate anus. In imperforate anus, it's part of a syndrome called Vacteral. We'll talk about Vacteral in a minute. But it's obvious when you do your newborn assessment, there's no hole. There may be stooling if there's a fistula. That's possible. But more than likely what you're going to see in the test is simply no anal opening, which is why you never do the first temperature check rectally. If you perforate the imperforate anus, what you've done is stabbed the infant and entered the peritoneum, not where you're supposed to be. All right, so you see that there's no hole. Because it's a problem with the GI tract, you're going to get an X-ray. But it's more than just an X-ray. You want to get a special kind, which is called a cross table. What you're trying to do is find out how bad the imperforate anus is, because the treatment is going to depend on whether it's mild or severe. Now, in mild disease, you can imagine that the imperforate anus is right where it's supposed to be, it's just not connected. You can see how this would not be that hard to connect together. So if it's mild, that is the ends are close to each other, fix it now. Some sort of surgical procedure. But if it's severe, where the imperforate anus pouch is far from where the anal verge is supposed to be, you want to wait for the baby to get bigger. right? So you have more colon, more stuff to work with, so you can connect it up better. This requires you do a colostomy now and then fix it later. And this doesn't matter, of course, because the infant's going to be incontinent stool anyway. You just have to reverse the colostomy before they start toilet training. But where they'll get you again on perforate anus is the Vactral syndrome. Vactral stands for vertebra, vertebral anomalies, and perforate anus, cardiac problems, tracheoesophageal fistula, esophageal atresia, and you could also count this as TE because effectively these are the same disease, as we'll learn in a later video. R is renal, and L is limb. Which means that you might say, aha, I know I've got imperforate anus, I've done my x-ray, it's close together, let's take him to surgery. Wrong. What you have to do first is an ultrasound of the sacrum. You'll have gotten the x-ray for the anus, echocardiogram, and a catheter with an x-ray. You pass a catheter, an NG tube, down, presumably into the nostril, down into the stomach. But when you take the picture, what you'll see is that it's coiled up in the blind pouch. Renal, you want to do a voiding cystourethrogram, and for limbs, you're going to get an x-ray of the wrist. The idea is that you need to prepare these kids for intubation versus surgery, so you need to know if their heart and trachea are good, so don't go to surgery until after you evaluated them for Vactral, even if it looks like it's a simple fix. Meconium ileus is effectively cystic fibrosis. And what happens in cystic fibrosis is you don't turn on enough water. Not enough water in the lumen causes this meconium plug, and then once it's effectively a bowel obstruction, and so no stool can move forward. This will present as a failure to pass meconium. But you'll either know that they had cystic fibrosis because you had a prenatal screen. Everyone in this country is screened for cystic fibrosis, so you're expecting it. Or the test will give you a reason that they have not had a prenatal screen. It'll be someone who has not had any prenatal care whatsoever. And the way they'll do that to you is by saying someone who just arrived, a refugee, an immigrant, or an undocumented worker who could not access the healthcare system, and now a baby's coming. Regardless, when you see a cystic fibrosis patient, or you have a failure to pass meconium, there's a problem with the gut, so you're going to get an x-ray. And the x-ray will show you the transition point. It may even show you a gas-filled plug. The best test for this is also therapeutic. Remember, cystic fibrosis patients can't secrete enough water into the lumen to dissolve meconium. So you should just do it for them. A water enema or a water contrast enema like gastrographin can be used to both diagnose the condition and also dissolve the plug. But again, just like in perforate anus, it's that easy, but you're not done. If you didn't know about it, now you want to confirm with a sweat chloride test. Because if they have cystic fibrosis, you're going to need to supplement them with vitamins A, D, E, and K. You're going to give them pancreatic enzymes because the exocrine function is dysfunctional in cystic fibrosis. And you're going to do pulmonary toilet to prevent respiratory infections. Hirschsprung's is sort of a double edge. It can present as a failure to pass meconium, or it can be chronic constipation later. The problem with Hirschsprung's is that there's a failure of migration. During embryogenesis, inhibitory neurons that allow for relaxation in the Auerbach and Meissner plexus have to travel across the embryologic landscape and innervate the colon. and this is always true, it always fails to innervate the distal colon. And the severity of the disease is how proximal the deinnervation is. So what's supposed to happen is that all these nerves are supposed to go out and grab onto the colon. What happens is that the most distal area doesn't, and then depending on how far up proximal it is, will determine the severity. Most kids are going to present with a failure to pass meconium within 48 hours. There will be a palpable colon because it gets so distended, and there will be explosive diarrhea on digital rectal exam. The idea is that your finger liberates the contracted colon and all the stool shoots out. And this is important to remember as we go through the diagnosis. It is a failure of inhibitory neurons, that is, in the area that is affected, the muscle can't relax. And if it can't relax, no stool can enter that space, and so no stool can get through. So even though there is contraction, it's sustained and prevents the stool from leaving the rectum. This occurs in about 90% of the patients. The other 10% are going to be chronic diarrhea with overflow incontinence. The idea is that if you've got enough good colon, you can push stool around the obstruction. And the amount of stool that's going to get around a rock-hard piece of stool is going to be liquid, so it comes out diarrhea. And if it wasn't bad enough to diagnose in the first 48 hours, there's some function there, so as the kid ages, it's going to be a little weird, a little off, but no one will really notice until they start trying to toilet train where they get overflow incontinence. And you'll see how overflow incontinence bleeds into voluntary holding. The diagnosis is going to begin, problem with the gut, with an x-ray. And this is important. The good colon is dilated. The bad colon looks normal. And that makes sense. If you've got contracted colon that's bad, that won't relax, it's squeezed out everything already and won't let anything else in. And the rest of the colon that has these inhibitory neurons so it can relax will, and it will just accept stool. Now, depending on what your presentation is, your next step is variable. If you're that 90% failure to pass meconium, what you're going to do is a contrast enema, like barium. It will allow you to see the transition point. If, however, you're in that 10%, what you want to do is anorectal manometry, where you're going to see increased tone, the lack of inhibition. Regardless of the second step, the best test is a biopsy, and it shows there is no plexus. Those neurons are missing. And once you see that this is the diagnosis, the treatment is to surgically resect the bad colon. And this is important. Again, you're going to remove the part that looks normal, but is biopsy abnormal. And then I spent so much time on Hirschsprung's because I don't want you to get confused when it comes to voluntary holding. For whatever reason, kids may hold in stool. This is usually for fear of pain and defecation or embarrassment. And since they don't know better, those with cognitive impairment generally are higher risk. And the idea is this: you cannot hold in your bladder. Eventually the wall tension gets exceeded and you force urine out. Stool, on the other hand, you can really hold stool for a long time. And the longer you do, the more water is absorbed. The more water it gets absorbed, the more concrete football it becomes. So even if you wanted to go, it's really hard to pass that stool. So the patient is going to actually have two major time points: when they begin toilet training and when they go to school for the first time. And what they're going to present with is initially voluntary holding. But voluntary may turn involuntary. And very much like Hirschsprung's, you may have that concrete football, but stool can get around. But the only type of stool that's going to get around the football is going to be liquid. So you're going to see overflow incontinence. And encopresis, stooling in the bed. The idea is because the mass movement happens, and they can't get out the hard stuff, but the loose liquid stuff that works its way around comes out when they don't want it to. The diagnosis for the most part is going to be clinical, checking about bowel habits. And the treatment is going to be a bowel regimen. And bowel regimen usually means stool softeners and motility agents. And then, of course, behavior. Tell the kid that it's okay to poop. But every once in a while, it's too late, they're impacted, you need to disimpact. And disimpaction, unlike an adult, should be done under anesthesia. All right, let's review. Constipation, slowing down of your stool. Failure to pass meconium, 48 hours, absolutely abnormal. Imperforate anus, you're going to see, decide whether you fix it or colostomy and fix it later, but don't forget about Bacterol and everything you need to do for it. For Meconium ileus, it's cystic fibrosis. Use water enema. The plug is cleared. Follow up with a sweat chloride test. See upper airway for more on cystic fibrosis. For Hirschsprung's, it's a failure of migration. The anorectal manometry will be increased. The biopsy shows absent plexus, and you remove the part with the absent plexus that looks normal on x-ray. And voluntary holding, tell the kids to not do that, but recognize that overflow incontinence and encopresis may be voluntary holding. But then don't forget about the other causes of constipation or failure to pass meconium. That is constipation.